as Indigenous people, it's our responsibility to indigenize the messaging
Hmm. Hmm.
so that people can take it up in a way that's safe and culturally appropriate. So it means something to them.
Okay. Well, today we're gonna be diving into the topic of HIV and AIDS, which we've talked about a number of times on the show in the past. But here's what makes me really excited about this conversation in particular is we're talking about HIV from the lens of from the Indigenous community and the sort of I guess like the advocacy work that needs to be going into that, and the advocacy work that is going into that, specifically from our friend Trevor, who we are joined with today. Trevor, thanks so much for joining us. Before we dive into you and all the work that you're doing, please give our listeners a little introduction into who you are.
Sure. Um, I'm a citizen of the Mississaugas of the Credit First Nation, and I live in the community. Last year, with the support of my community, I built a house, and I've been living here for a year, so I'm still feeling excited, and I just can't believe it's true. Um, in 1990, I was diagnosed with HIV, and that was before there were any effective treatments. People got HIV, they were okay for a while. After 7 or 8 years, they get really sick and then basically die, surrounded in stigma and discrimination. So that was the early days. Lots has changed since those days, but that was the outlook I had when I was 25 years old. I work with CAN. We used to be called the Canadian Aboriginal AIDS Network, but now we're called Communities, Alliances, and Networks. So we're still the CAAN. With all the decades of experience we have responding to HIV, we've taken on tuberculosis, we've taken on hepatitis C and other hepatitis, sexually transmitted infections, harm reduction, addictions. We call it sexually transmitted and bloodborne infections. So we've expanded a lot. So I'm not just working on HIV and living with HIV. I'm also everything we've learned we're applying to Indigenous peoples and other infectious diseases.
Mm-hmm. I mean, 20. Did you say 25 was when you were diagnosed with HIV?
Yeah, I've been living more than half of my life.
Okay.
With HIV.
So when you were diagnosed, at what point? I mean, where were you at in your life at that time, and at what point did advocacy for HIV sort of become your life and your life's mission? Like what was the transition there from being a patient to transitioning into being like a real true patient advocate who is getting your hands dirty in the world of really trying to create like big change in that world?
That is a story, isn't it? So diagnosis in 1990, and at that time I was working, and I had been working in the late 80s, and saving money somehow. Even though I wasn't making a lot of money, I was saving money. In 1990, on my birthday, I flew to Europe and hitchhiked around Europe for 5 months and came back in the fall. That was so cool. It was like, I don't have a formal education, so that was a beginning of a worldly education for me, right? I came back and tested positive for HIV. I had been basically standing in harm's way. I left home very early. I got involved in sex work and started using drugs. I had some time in jail, so I know a lot about the key affected populations that often are exposed to HIV, and that was tough for me. I got married to a woman in 1993, and we lived together and had an organic farm. We moved to Seattle. And then as a Canadian there, I had no health insurance either, and living with HIV and starting to get more and more tired. At the end of 1997, we moved back to Canada because I was thinking, well, I'm going to end up getting sick and dying at some point, and I need health care. And so my wife and I moved and started a certified organic farm. We were doing that for 5 or 6 years. And we moved back to Ontario so I could be closer to my son from a teenage dysfunctional relationship and to be closer to my son there. And I got sick when we were, on the farm, and I was landscape installing and very healthy, as living as healthy as I can, eating pure, working, trying to cut down on as many, toxic stuff putting in my body as I could. But I got really sick. And this was in 1996 at the International AIDS Conference in Vancouver. They announced the new antiretroviral treatment, the AIDS cocktails. People were getting off their deathbeds and going back to work.
Mm-hmm.
But I didn't trust the system. Universities, hospitals, prisons, it's all the same to me. The medical system, it was all the same to me. And for many Indigenous peoples, it is like that. That's what I was told. Be careful, protect yourself from these entities which can chew you up, spit you out. So I didn't even believe, there's like COVID, there was a lot of conspiracy theories about the treatments and stuff. With pandemics, it gets like that. People get a little crazy thinking that these restrictions and guidance are bad for you, and they're trying to manipulate you into some global conspiracy. And I was actually thinking a lot in that way. Plus, keep in mind that I was starting to develop dementia. I wasn't thinking very clearly. And so my mistrust of the whole system got so much. So I was laying on the couch. I couldn't move. And to get up to go to the washroom and walk to the washroom and back was exhausting. And I'd have to lay down and sleep for 3 hours just from the exhaustion from walking. Everything tasted so strong. But my wife and my son, out of love for me, convinced me, like, you're in denial. Get to the specialist, get these meds to save your life. And I did. So I was feeling physically better. Start right away. It was like taking speed or something.
Yeah,
I was like, woo, because I forgot what it was like to have a normal energy level, right? Because I was just pushing, stubborn, and until I couldn't anymore. So while I was getting better, a friend of mine, a mentor and a friend who I had actually met in a gay leather bar in Toronto, this Indigenous older person who was a leader in the Two-Spirit community in Toronto, and the executive director of Two Spirited People of the First Nations. He said to me, listen, we're having a big AIDS conference. The Canadian Aboriginal AIDS Network is having a big AIDS conference in Toronto, which is your territory of the Mississaugas of the Credit First Nation. We want you to come to this conference. And this was in 1999.
Okay.
And I went there, and I was in a big healing ceremony for 2 days with elders and others Indigenous people living with HIV and traditional healers. And it kind of set me emotionally and spiritually. I was healing not just my body, and I was getting reconnected with my Indigenous culture and elders and teachings. And I heard this Haida elder from out west was looking for me at this conference in Toronto. And I was like, oh no, Haidas are tough. And she tracked me down. She said, you're Trevor Stratton. You're from Mississaugas of the Credit First Nation, right? And I was, yeah. And she said, I want you to take this tobacco, our healing medicine, and I want you to take this back to elders in your community and thank them for allowing us to have this meeting on your traditional territory. And I was like, okay, I'm going to do this. I promised her I would do that. So, when I was driving there, I'm like, yeah, I'm on a mission, joking in my head. I'm on a mission from God. And I was like, hey, wait a minute. I am here. Here I am driving to my community with this medicine, this physical medicine, right? To share it with my community and thank my community. And when I got there, I didn't know any Indigenous traditional elders. I went to our chief. I went to chief and council and knocked on the door, and the chief came out and she looked at me, and I told her the story and how raw I was from this Indigenous AIDS conference. And she says, you have AIDS? And I was like, yeah, I do. And she said, well, that's good. You need to come and help our community with what you know and what you have. I want you to go talk to your cousin Carla. She's the community health director or the community health representative at our community health building. So I go there, tell her the same story. Hey, Sheila. She's like, you have AIDS? Yep. She said, that's great. Can you come and speak at an HIV/AIDS workshop in 3 weeks that we're having here in the community? And so that was the first time that I ever did anything in response to HIV and AIDS. And I just built it. And there was and 2/3 of the people in the room were my family. You know how big our families are on the
Mm-hmm.
reserve.
Mm-hmm.
And the aunties were all lined up and they were hugging me one by one, telling me that I'm strong. And then we have down the road from me here is the Native Horizons Treatment Center. It's for drug use and addictions. And they brought a lot of their people too. And so behind the aunties were these big, burly, truck driving, biker looking guys, hairy arms coming toward me slowly. And they were hugging me. I'm just skinny. So I was like, they're big boys, right? And they're patting me on the back. Yeah, you're a warrior, brother. And that really inspired me. And the word got out, and I started speaking at different First Nations, different communities. And then eventually I attended another CAN annual general meeting 2 years later, after 1999, my first meeting where I had that healing experience. 2 years later, I went to Vancouver. I was elected as the Ontario board member, the Ontario representative. So I got on the board in 2002.
Wow.
Yeah. And at the same time, as I was in Vancouver, I went over to a lady's friend of mine. She's not Indigenous, she's European ethnicity. And I said, listen, I'm at this big conference and everything. I brought you a braid of sweetgrass. One of our medicines is sweetgrass. And I handed it to her and I said, this is medicine for you. And she said, I have something for you. And she goes into the back room. She comes out with this great big eagle feather. And an eagle feather to a First Nations person is not just, it's not a possession. It's an entity. It's a living thing with its own will. And for that to come to me on the day that I was elected to the board of CAN, I was sure this is what I'm supposed to do. Yeah, an important day is when I was born, but another really important day when I realized why I'm here. What am I here to do?
Right.
Cool.
And that's important to Indigenous peoples, connecting to my culture, sharing what I know, just trying to be a part of positive change.
What a beautiful story.
Totally, yeah.
I mean, one thing that just kind of popped up, and this wasn't even on my list of things to touch on, but I'm curious now after hearing your experience there. Oftentimes whenever we talk about, I mean, anytime we've ever talked about HIV/AIDS on the show, it's mostly been from the sort of context of the general population, oftentimes from from a lens of like the LGBTQ community. But again, I think this is the first time we've dived into the topic surrounding the Indigenous culture here in Canada. Mm-hmm. And I'm just curious about when we talk about AIDS, HIV from a general perspective, there is still, even today, there is still HIV is filled with shame and
stigma and discrimination,
discrimination
and criminalization.
Yeah,
right? Like it goes further.
And so I'm curious, like from the Indigenous culture, from the Indigenous population and Indigenous communities in Canada, is and like siloed from the rest of Canada. How is HIV and AIDS viewed? Is there that feeling of shame, that feeling of stigma within the community itself? Because your story of these guys, these big burly men who came up to you and just swallowed you up in a hug and said like, "Hey man, you're like, let's go, brother. Like, thanks for sharing." To me, that feels like that perhaps there isn't that same kind of shame and stigma that's mired in HIV and AIDS in general, when you compare it to the general population.
I think, over the years, stigma and discrimination, I think in this country has gone down. Mm. It's still there. Mm-hmm. If you're a gay white man, you're probably getting the least discrimination of anyone. Mm-hmm. I mean, the systems here were made by Europeans for Europeans without others, really, people of color, Indigenous people, taken into consideration. And let's not forget the racism that exists. Mm-hmm. CBC had to shut down their comments sections after their any Indigenous articles because of the disparaging comments and the racism that's unleashed mm-hmm. by people in the general public. So And then you have to consider the lack of information that gets into our Indigenous communities. And HIV/AIDS is just one of the things that can hurt us. There's all these things around. There's diabetes and tuberculosis and all these different things that Indigenous peoples experience. And we have a lower life experience as well. So there's the lack of accurate information. There's a distrust of the systems, like I talked about
Yes.
in
Yeah.
my own self. And then there's the racism. And then there's the HIV/AIDS stigma and discrimination is very strong in our communities.
Okay.
And that's the power of the voice of people living with HIV, to be able to reach someone on a very personal level
Yeah.
and turn them around so they realize, oh, this could be my aunt.
Mm-hmm.
This could be my
Right.
daughter, my
Right.
son, my
Mhm.
nephew. This is a human story. This isn't about monsters.
Yeah,
Mm.
that's what I
Mhm.
took away from the story that you told too, and you know, going up to the chief and then to your cousin and then being like, oh my God, you have AIDS, almost like it was a good thing because here you are, this person from the community with this lived experience who they see as somebody who is going to be that person who can talk about it
Willing to share. Yeah.
and I'm curious because that also makes me think about, you know, you described it through your experience in the early 90s with that, you know, fear of the system itself, you know, the hospital, healthcare, the prison, it's all the same sort of thing. What is it like trying to communicate these ideas within your community that there is, you know, treatments available and that there has to be some level of trust? I imagine that's like a really difficult balance
Mhm.
to do.
We have to be careful, I have to be careful not to overgeneralize Indigenous peoples.
Mhm.
There are Indigenous peoples who go to the hospital and, follow recommendations and all of that. Um, it's often our people, especially the ones just, dashing around, struggling to have a good life. These are the ones that are most at risk, I think, and the most distrustful of the system because of a misunderstanding of what the system is. Yes, it can be violent, but there's ways of navigating that. So we also have peer navigators. We have Indigenous people living with HIV who help other Indigenous people living with HIV, especially newly diagnosed, to, you know, first of all, if they've never been tested, to go get tested. There's HIV self-test kits now where you can get your result in 10 minutes. And then to get on treatment and to adhere to the treatment so that you can maintain or achieve that undetectable viral load. And that
Mhm.
means that the HIV in your body becomes so low, there's so few, pieces of HIV in there that it can't be detected by the regular test. And that's called being undetectable.
Mhm.
A person that is undetectable cannot pass HIV sexually.
Mhm.
Our people don't even know that. And it's the peers, we tell each other that. And it's so liberating, especially for a young person,
Yeah.
someone who wants to have children, to hear that, oh, I'm not a vector of disease. I can't pass it on. And it's 100%. This is science, the
Mhm.
science that we don't trust.
Mhm.
So it's hard to sell it unless you're a person
Mm-hmm.
who doesn't have HIV. Maybe you're very sexually active and two-spirit man, and you don't have HIV because you've been taking PrEP for 5 years, which is a pill that prevents you from taking HIV. That information isn't getting to our people.
Mhm.
And it's our people who need to translate that information in a culturally safe and culturally appropriate way that doesn't have some of the violent terminologies that are used in the English language.
Mhm.
And the values, everything has a value. This is greater than that. Indigenous languages are about actions. So the way you have to sell an idea is through action, not through this is greater than that and comparing objects and things to
Right.
each other.
Trevor, when you were diagnosed in 1990, that was the year I was born, and
Yeah.
and my mom's best friend, her brother, had HIV and then AIDS and died
I'm sorry.
before I was 10 years old. And to me, obviously, at that time, between being born and being 10, obviously, I'm not
really exposed to like exactly why. It's like, you know, Bobby's brother died because he was sick, and I don't really understand. It's not until years later that I get the kind of backstory. Like, you know, Polly had AIDS and he died from AIDS, and this is that, and then understand, and then gradually over time starting to understand like what AIDS, like what the circumstance of AIDS was in the 80s and 90s, and trying to kind of like understand the backstory and the cultural sort of view of it. You know, can you paint us a picture of like what it was like in 1990 to get that news, what it like meant to you, what were the things that kind of like flash before your eyes when you get this diagnosis, and what the view of the outside, the general population, whether specifically from your Indigenous community or just the population at large, like how HIV and AIDS was viewed at that time?
It you know, we were considered pariahs, basically. In the 80s, I remember, you know, Gay Pride in Toronto, and they'd be honoring a person living with HIV for activism. And remember, wasn't medications in those days, and they'd be on top of this big float at the very top with a crown on, maybe, and covered in purple lesions and skinny and gums all, you know, infected, and they'd be gone in 6 months. That's what it was like. It was absolutely terrifying in the gay village. And anyone who, especially men who were gay and actively sexually active, it was a very terrifying time. I lost hundreds of friends, and let's not forget that people are still dying
Mm-hmm.
of AIDS in Canada, which is pathetic. Babies are being born with HIV in Canada still, and that in this day, that's unacceptable. But I remember things like, you know, a community barbecue out on the balcony of a bar in downtown in Toronto, and a drinking buddy of mine. I was a party animal, right? I was doing everything. I was having a really good time expressing my youth and just figuring out where the boundaries are, you know, and I put myself in harm's way and ended up getting HIV like many other of my friends. One friend, you know, we had talked about HIV and others who were dying or getting sick. And oh my God, doesn't he look good today? Oh, he had his lungs drained today, so he's having a beer. You know, this is what life was like. But I remember my friend Peter coming up to me and grabbing me by both sides of the head and looking at me in the eyes. And he said, "Trevor, I have a tumor on my brain." And I was afraid of him after that because it terrified me, because I was looking into my own face. And he was gone. That was the last time I ever saw him. Those are the stories. The stories of Indigenous people who are two-spirit, you know, gay men coming. And don't forget, the Indigenous women stood with us the whole time. They were strong. The Indigenous women's health movement stood with gay men who were dying, Indigenous gay men who were dying. But there were examples of, you know, you were talking about stigma and discrimination in our communities, where people would come, Indigenous people would come from their home fire communities to the city so that they could be gay, so that they would be in a safer environment, and then get it, and because they were discriminated against at home and in the community, and then die of AIDS in the city, and not allow the body to be buried back home because people are afraid of getting HIV or HIV getting in the ground, things like that. Or a family that has shunned their community, their family member who has HIV, that person is being taken care of by other two-spirit people in the city until they die. And then the family comes into town and cuts off all those friends and all that support and takes the body home and has a funeral and cuts off everybody from the family that loved them for 20 years and took care of them on their deathbed. This we just had to accept these things and keep going. Before there were AIDS service organizations, there were teams of friends sitting around the bed holding our friend's hand. Don't worry, we will change the cat litter. We'll change your diaper. We're going to take care of you. And this was with no money. And that's how AIDS service organizations began.
Yeah.
That's the grassroots. And now we have, you know, appointment only, and it's all quite institutionalized now. which can create a barrier for those who are still struggling on the ground just to have a good life.
Mm-hmm.
I know that the work that you are doing at CAN, I mean, some of it pertains to what you've already spoken to, which is like the prevention strategies and um, uh, communicating the science and the facts that exist within the literature right now when it comes to prevention strategies for HIV/AIDS in the Indigenous community. But another thing that I'm just so curious to kind of dive into is the importance of Indigenous specific epidemiology. Can you give us some insight into what that means? What is the work that you are doing to try to try to, I guess just make more noise of the importance of this specific epidemiology, and the way that we sort of the way that science in general is including the Indigenous communities when it comes to studying AIDS, HIV across Canada.
Mm-hmm. In statistics, HIV statistics and epidemiology for Indigenous peoples is hard to come by for HIV. In Canada, the US, New Zealand, and Australia, we have some pretty good statistics. But, even national statistics, like, we know that in Canada, almost 60% of people who are getting HIV are men who have sex with men. So, but in the Indigenous community, it's almost 50% of the Indigenous people who get HIV are women.
Mm-hmm.
So that's a different scenario. All human beings get HIV the same way biologically, but attitudes and behaviors and understandings are different and contextually different. So national statistics don't always never tell you what's happening locally.
Mm-hmm.
What's happening in Thunder Bay, what's happening in Toronto, Vancouver, Whitehorse, all these communities is different and contextual. And that's why we need the data, disaggregated data, meaning you tether out the Indigenous statistics and analyze them so that Indigenous people can mount an evidence-based response.
Mm-hmm.
If we look at the national statistics and go after men who have sex with men, thinking that 60% of our people are men who are getting HIV are men who have sex with men, we're off the mark. We're missing our women. The other thing is almost 60% of Indigenous people that get HIV now get it through injection drug use, not through men who have sex with men, same sex. And the second mode of transmission for Indigenous peoples is heterosexual sex. And it's the third mode of transmission, which is men who have sex with men.
Mm.
So, that's important.
Because like the oversight and the accountability and the
prevention strategy.
The prevention strategy,
yes.
the assistance to figuring out the problem, like that all that all pertains to that data. And if that data is skewed, then
if you go off of what my thought of HIV/AIDS on the forefront, like the first thing that would pop up into my head, and it's because it's what I hear the most in terms of HIV and AIDS prevention is safe sex.
Right.
And like that's going to be the number one thing when you look at if you're looking at it from what we talk about as an entire population across the country from coast to coast. But if I'm an Indigenous person and that's what I'm hearing and I'm understanding, then I'm thinking less about the more probable ways that I'm going to, that I could be exposed to HIV, and therefore thinking less about the prevention that I could be taking into consideration when I'm doing other things and that aren't having sex with, that aren't men having sex with men.
Yeah, that's the thing. The new technologies and new information is slower to reach our people. So, for example, pre-exposure prophylaxis. That means you can take a pill that prevents HIV. It prevents you from acquiring HIV, at least sexually, and it reduces the chances even intravenously. Now they have DoxyPrep coming out, which is an injectable which you take every 2 months, and it's slow release and prevents
Mm.
acquisition of HIV. We have injectables for antiretrovirals too. So let's say people who have trouble taking their pills every day, you can take an injection, like I said, that releases your HIV meds for 2 months. There's another one that's in the pipeline coming down for 6 months.
Hmm.
We have HIV self-testing now. These things aren't really getting into our communities. The concept that if you have an undetectable viral load, that you can't pass HIV sexually, these aren't being taken up by our people.
Mm.
So as Indigenous people, it's our responsibility to indigenize the messaging so that people can take it up in a way that's safe and culturally appropriate. So it means something to them. These advertisements for highly sexualized advertisements for HIV prevention with two nearly naked men almost having soft porn together, that's not reaching our women with children whose children are being barred from school in the communities. And we talked to our Two-Spirit men, even if you want to focus just on Two-Spirit. And we showed them all these different messaging in a study. This is going back 15, 20 years. And asked them which one is the most compelling, which would make you look at it and take in the message. It's a big close-up of grandma. And it says, use a condom because grandma says so. That was the one that our Two-Spirit people wanted.
Yeah.
They didn't want the sexualized men. This is, we never would have guessed that, actually. I wouldn't have, but we asked them.
I know that we touched on this. We've touched on this a little bit already, but I'm very fascinated by it because we're working on another podcast series, and one of the episodes looks at barriers to access for people needing care and caregivers in Indigenous communities, and it's specifically around. We speak with a researcher who studies autism in Indigenous communities, and a big part of that conversation was the mistrust of the healthcare system, going back to this person's mother's experience in a residential school and all of the trauma that came from the residential school system and passed on through generations and creates this mistrust because of this, this long history of racism and discrimination and abuse. And just like, I'm so curious about that like when I was reading about this and hearing this in this conversation with this guy, I was like, wow, this just seems like such a just a gigantic mountain to try and get over, to try and to like how big of a barrier trying to just get past this mistrust that comes because it like we did it, like we gave it to Indigenous communities, this like very legitimate reason to not be trustful of as he put it, authority in general. Like anything that came from like an authoritative lens was just like immediately the response is, okay, skepticism from authority. How big of a challenge is that, and how I would assume that is very much so still a thing that is happening today and needs to be worked on today, like building trust back with the healthcare system. How do you go about that? How do you communicate that to try and build trust?
That is a big question. Wow. Yeah, we're talking about multi-generational trauma here, aren't we? Mm-hmm. The Royal Commission on Aboriginal Peoples, 20 more years ago came out. And in that, that's where they identify that Indigenous people have this collective trauma that's passed down for generations. And they didn't invent the concept. The concept was discovered because of Jews that lived through the Holocaust. They understood why they were traumatized, but they couldn't figure out why their children and the children's children were traumatized. And that's where it was identified about this multi-generational trauma. And they decided, yeah, look, that's what's happening here with Indigenous peoples. And I can say I've lived that. We have a document that we put together. It's a policy brief, and it's called Indigenous Harm Reduction equals Reducing the Harms of Colonialism. We believe that it goes, you can go back to addictions, and then, they say, oh, you got to go back further. That's just a symptom. And you go back further and you start mental health and childhood, formative years stuff. For Indigenous, it goes even further. It goes generations back to
Right.
where these feelings of low self-esteem come from, the distrust of the system. But we have something now. We have tools, recently developed tools, like the United Nations Declaration on the Rights of Indigenous Peoples. This is about redressing the harms of colonialism. And in Canada, we now have a legislative act from the federal government. It's the UNDRIP Act, the UN Declaration on the Rights of Indigenous Peoples Act. And that's about implementing the recommendations from UNDRIP, from the United Nations. And CAN is actively involved in providing, the government created goals and targets every year for attaining the recommendations in the UNDRIP Act, which is called UNDA. And they actually asked a number of Indigenous communities and organizations, we want you to create goals and targets from the Indigenous lens, and then report on the achievement of these Indigenous indicators yearly. So this is one of the ways that it can be redressed. It's systemic.
Mm.
And the only way to change the system is through policy change and legislation change. But also, it comes from the mindsets of human beings. This legislation is created by human beings and corporations, of course.
Mm-hmm.
Yeah.
I'm curious, Trevor, like from your experience, what are the things that you've personally seen to be most effective?
I think that the harm reduction approach is very effective. And that is about walking with people, walking beside them, not leading them, not pushing them from behind, but just walking with them.
Mm.
And starting where people are at, what are they ready for? Maybe they're just ready for a coffee and not even a name. Maybe all they need is a clean, a sterilized syringe that day, right at that moment. So imagine these harm reduction outreach vans that go out for people who are, trying not to feel that multi-generational trauma and numbing themselves so they can just feel normal, and then end up getting trapped in that spiral of addiction where just to feel okay, I need to just not to shake on the ground. I need to keep taking these drugs. And it also makes me not think about all these traumas. So that's because, look, you give that person a needle. Let's say it's a 18-year-old pregnant girl wants a needle, and it has been coming for 2 months, and you finally you've learned her name and she knows your name. She asked for you because you've been developing that trust. And then one day she rolls up her sleeve and shows you a huge infected arm, that's from injecting, and it's all infected with all this stuff. And she says, this is hurting my business. I can't get customers anymore. I need help. And then that's what they're ready for. Mm-hmm. And eventually they might say, I'm pregnant. Is there any help I can get? Do you know what I mean? That trust starts to develop in one individual. It just takes one sometimes to keep people from falling off the edge to the point where they may decide to cut down or reduce the harms. But it's walking with people. You can't push them.
If you have let's say you go and talk to an Indigenous community on the topic of HIV and AIDS, and somebody who is listening they have these feelings of mistrust, and as a result of hearing you speak, they're like, okay, I want to go and want to seek some the medical attention that could help me. On the flip side of that person's going into a healthcare setting, and something that we've talked a lot about on the show in the past on numerous topics is that when you go to that place, that the people that you speak to, the importance of them recognizing that an Indigenous person walking into that space is entering that space through from a different perspective, and like just recognizing that perspective and understanding that person might be coming in with certain apprehensions or whatever it might be. like, is there, and I guess not just on HIV and AIDS, but on the topic of like anything healthcare related, when an Indigenous person comes into a hospital or a clinic, is there anything being advocated for that, for like an understanding from the healthcare professional's perspective that somebody that's coming in might need to be approached in a bit of like a non-stock way, like a non-stock population sense, that you should be thinking about, okay, this person's Indigenous. I'm changing my tact because I know that this person's is coming from it might be coming at this from a completely
They have
different
different
lens.
needs.
Yeah.
Mhm. Well, I don't believe doctors are obliged to take any additional courses after they get their degree and start practicing. I don't think there's any obligation. So it's really about how then do you reach out to them so that they realize that there could be an issue within your hospital, within your clinic, or whatever. What a lot of hospitals are doing now is creating in changing policies. For one thing, Indigenous families are huge. If someone's dying, the whole family gathers. And for that limit of 2 people, only up till 10 p.m., that doesn't work for us. That's an example. Indigenous healing room where we can smudge, where we can do our rituals and ceremonies. That's another important thing. Indigenous peer navigators and liaisons in hospitals are becoming a real thing now. And that really helps because, many Indigenous peoples use English and French as a second language. It's not only about education. It's about, not understanding completely the language and using it in a different way than employees of an institution would use, right? And some of that is just like a dictionary's talking to me. I don't get it.
Right.
You need to talk to me like a human being. And the last thing I'm going to say about that, an Indigenous person afraid or mistrustful of the healthcare system may take 2-3 months or even years to work up the courage to go into that office. And who's the first person they see? The receptionist. That's all it can take. If the receptionist won't even look at you and you're standing at that kiosk for 5 minutes, many of our people will just walk out because they've been insulted. Their sentient being has not even been recognized by this other sentient being. And to us, that's a cultural no. You don't do that unless you don't like somebody. The whole concept of, look someone directly in the eye and give them a firm handshake, that is so insulting to an Indigenous person. That's aggressive. You don't look at someone's eyes. That's like a challenge, and it's aggression. Indigenous people often look down and you shake their hand and it's really soft and it's like limp. And that's because they want to, even the biggest man, because they want to show you how gentle they are and how safe you are around them. So these little things, all these little things, how do you teach that to a non-Indigenous person? It's a challenge. It's a huge challenge. And why should they care? That's the other thing.
Well, Trevor, I got to say, like, this has been an absolutely fascinating conversation. And just to know that someone like yourself is out there who can speak so eloquently to these issues, these challenges, and these necessities when it comes to educating, not just the Indigenous communities surrounding HIV and AIDS, but also to 3 guys like us, who like, these are things that are valuable for us to know, valuable for all of our listeners to know. And I feel so grateful that people like yourself are out there doing this work that is so meaningful. And I know prior to the recording starting, we were talking about how you were set to leave tomorrow or the next day to the International AIDS Conference over in Munich. And so just to know that there's, a cohort of folks from here in Canada heading over there to help, again, drive this work is just so meaningful. If you wanted to leave one last sort of message to the folks out there listening, please, what would it be?
HIV/AIDS is a huge challenge. We've said that I mean, Canada bought into it, the United Nations. We've said that we're going to end AIDS as a public health threat by 2030. That's 6 years from now.
Mm.
And those are the sustainable development goals, right? There's 17 of them, and all these lofty, very ambitious goals that we're all supposed to achieve by 2030. The only, we can't get, could the world call HIV eliminated as a public health threat without addressing Indigenous peoples? If we're only 5% of the world's population, then 95% of everybody else, the 95% is no longer, it's eliminated as a public health threat, but not, are we considered the public? Could they claim that they've achieved their goals, even though Indigenous peoples still have high rates and we're dying of HIV in 2030? The only way that they're going to get there are two things. They need to involve Indigenous peoples and other severely marginalized groups that don't get the support that we deserve. And the other thing is the active and meaningful engagement of people living with HIV. From the very beginning, when they're working into new concepts and coming up with new ideas, to the very end and completion, the implementation and completion and evaluation. Indigenous people living with HIV need to be engaged at every level, and people need to stand by us and help us build our capacity so that we can respond with an Indigenous-led, culturally appropriate response to HIV here in Canada and globally.
Mm-hmm.
Beautiful. Honestly, this has just been such a lovely conversation. We thank you so much for taking time out of your schedule to sit down and chat with us. This really means a lot.
It's a great pleasure. And lots of my friends know about this podcast, and they're looking forward to the release date.
Thanks, Trevor.
Awesome.
Have fun in
Thank you.
Munich. Yeah.
Thanks, guys.
Okay. Well, thanks, Trevor. What a sweet man. Actually, as soon as the recording ended, he took us via laptop out to his
Oasis.
veranda. Yeah. And I was like, dude, A, your internet's great. B, why didn't you record from out here? It was beautiful. Oh my God. He lives on the most beautiful property. That's what it sounded like. He was like, it was very beautiful. Okay. All that talk about HIV.
What did it make you think about, Jer?
It got me thinking about the recent news coming out of the World Health Organization. Surrounding the news around Mpox. So the World Health Organization, and so you know what, the reason I wanted to kind of cover this is because I want to give the folks some real talk, because I feel like, I don't know, man. I don't know about you guys, but for the last little bit, I've been, every single time I've hopped on either Instagram or Twitter, especially Twitter, man, Twitter is a fucking dumpster fire.
How often do you use Twitter?
Pretty regularly. Like I use it a lot to try to find content for these wrap ups. I use it for.
You're not a poster though. You're you're a lurker.
I'm a lurker.
You're not a gas on the dumpster fire guy.
Not really, no.
Okay.
But what I will say is that social media, for me personally, as of late, I've been finding to be
detrimental.
No, not so much. Like my screen time has dropped quite a bit. But what I've noticed is now that maybe it's because I've taken some time away from it, and whenever now I go in, I almost see like, oh, why are y'all talking like that? Like why is everyone blowing everything way out of proportion?
Yeah.
You know what I mean? Like it's just everything's on fucking 11, and I'm going, this is not the world.
That's what
the same reason
for.
why we blow things out of proportion, so people will like and review and subscribe.
Yeah, but we do it for fun. The shit I'm seeing is like, it's not for fun.
I actually
No,
guys,
it's not for
I
fun.
It's kind of for sad.
I have an
It's
idea.
really sad.
I have an idea for an app. It's just the comment section of any post. So like instead of seeing any pictures or
God,
articles
that sounds
or
even
anything,
worse.
you just scroll comments all day.
That's the worst part of it.
Smug, sanctimonious bitch.
So the reason why I wanted to talk about the Mpox situation is because I've seen a lot of headlines about like Mpox coming at you, like it's coming quick, and it's gonna fuck you and your family.
Yeah, here comes the next lockdown.
That's right.
Yeah.
So here's a little breakdown of what I read from a very this is from Fox News. Okay, so here we go. The World Health Organization, WHO, and the Africa Center for Disease Control and Prevention, Africa CDC, have declared the ongoing outbreak of Mpox, formerly known as monkeypox, a global public health emergency of international concern. So there is some concern here.
I know exactly where this is going because I've been living in those comment sections. I bet that WHO is saying that we need to all lock down, right? Because that's what they want us to do.
No, they're
right?
actually
they want
not.
to control us.
They're actually not. So
I don't know.
Can we back up for 1 second?
Yes.
Because monkeypox, formerly monkeypox, now
Yes.
Mpox, because less letters, was
Why are you
a
doing the
thing-
Trump hands?
It was less the most less letters I've ever seen.
Taylor's views get more right wing when his hands go like that. He's about to say something crazy.
No, it reared its head. I don't know what was that, like a year and a half ago, and it was like there was cases in the States, and then there was a whole bunch of information that was coming out, and it was like this is false and this is what's real, and I feel like there was a whole thing about where the gay community was more at risk, but now I can't remember if that was true or false or what the deal was. I can't remember at all.
In Africa, there was a majority of people who were gay who were it was being spread within the gay community, but it's not just a sexual transmitted disease that is specific to the gay community, like HIV. But like HIV, the gay community was being affected by it in a bigger way than most, from what I gather. I haven't done any research into this at all, but I think it literally says that here coming up. So this whole thing about it being an emergency of international concern raises questions about whether or not Mpox could become the next global pandemic similar to COVID-19. However, this is the big part that I wanted to cover. Experts believe that while the situation is serious, it's unlikely to escalate into a global crisis like COVID-19.
That's what the WHO said, because I'm pretty sure they're the bad guys.
Well, it depends on whose podcast you're listening to.
That's Red Team, right?
Mpox is not a new virus. It has existed for decades, primarily in Central and West Africa. The virus belongs to the same family as smallpox, which was eradicated in 1980. Here's a quick little photo of some Mpox.
Nice.
It
Mpox
looks like AI generated.
It does kind of, doesn't it?
Very much does.
Mpox typically spreads less easily than COVID-19, and there are already vaccines available to help prevent and contain outbreaks. So the thing that got me thinking about this entire thing was like, okay, COVID was a novel virus that just fucking came out of nowhere. We had no idea what the fuck it was. We still don't really know what the fuck it is capable of doing,
or where it originally came from.
Well, it depends on whose podcast you listen to. But Mpox, monkeypox, has been around. It's been around. We're pretty familiar with it. We know how to treat it. I think this is more so of like getting information out there, knowing what the signs are, knowing what to look for, as opposed to the entire global health community being like, "Oh, what the fuck is this thing? We have no idea."
Wait, but isn't the WHO, aren't they the people who just want to lock everybody down?
Jesus Christ.
Brian, you got some strong thoughts on the WHO.
Actually,
I told you guys.
We actually have Alex Jones calling in.
Brian, what are you doing with your hand? Why are you moving your hands like that?
I told you guys, I read a lot of comment sections, and this is what I've been hearing.
But here's the thing. The disturbing aspect of the current Mpox outbreak is its similarity to the early spread of HIV during the AIDS pandemic. In 2022, a milder strain of Mpox, known as Clad 2. Now, I don't know if this is Clad 2, Clad II, or Clad LL. I really can't tell. And I'll tell you why. Because there's another clad that comes up here in a second. So, okay. So this began spreading in Western countries, particularly, specifically Western countries, particularly among men who are having sex.
Oh, okay.
And this strain has infected over 100,000 people in 116 countries, Clad 2 of Mpox.
Right.
But the mortality rate is very low.
And that was like the recent, like most recent before.
That was back in 2022.
Yeah.
Now, in Africa, a more severe strain of Mpox clad, now this is either capital I, lowercase b, or it's LB, or it's 1B, but the 1 is a numeral.
Right, because no one's telling you whether we're looking at Roman numerals or letters.
So I don't think it's 2 I's. I think it's Claude LL, which is wild to me. Why? It can't be Claude 2, right? Because this is Claude
because that's an AI platform.
Claude 3.5.
Yeah,
Right.
yeah. I think it's Clade.
Sonnet.
Clade.
This is the Sonnet version.
So this new severe strain of Mpox, Clade LB, Clade Pound, has emerged. And this strain actually spreads more easily, though casual contact and through casual contact, and has a higher mortality rate. So this is like just hanging out, high five in your buddy. You're gonna get some clad.
This is why we need lockdowns.
Well, no. So
take the children out of school.
The Democratic Republic of Congo has reported over 15,000 cases and 537 deaths. Though the actual numbers are likely higher due to limited testing and surveillance. And children are particularly vulnerable, representing 70% of the cases and 85% of deaths in Central Africa.
Fuck.
So again, this is the reason why they're definitely going, hey guys, this is a massive issue. We got to fucking keep an eye on this. But also, it's not end times.
Let's not do that thing again.
Right, exactly. Yeah. So in summary, while Mpox is unlikely to become a global pandemic like COVID-19, it poses a significant threat, particularly in marginalized communities and regions with inadequate healthcare infrastructure. And the response requires a coordinated global effort to ensure that resources, including vaccines, are distributed fairly and effectively, which again, kind of hoping we learned some lessons from COVID, because those communities that were more marginalized, those countries that were not as first world as maybe us here in Canada, they really got fucked.
And
during COVID.
I mean, so this is to the point about like marginalized communities being more affected by things like this, by Mpox in particular in this case, but like, most things. I've been looking into HIV a lot lately because of an episode that we're doing with another show. And I was looking into death rates in the 90s for HIV. And the death rate for it was either Black communities or people who were of more than one race were, let's say, like the overall death rate for HIV. I can't remember the period of time, but it was like 0.3 per 100,000 or like 1 per 100,000. And the death rate for the Black community was 24 per 100,000.
Mm-hmm.
So like a factor of 24 times greater than like the general population, like, which is astronomical.
Sounds like you're saying that it was way worser for them.
Like way worser.
Yeah.
Way worser. And I mean, that's for a whole fucking slew of reasons that we have a lot to do with in terms of our countries, North America.
That's wild. I just can't. I don't know, guys. Correct me if I'm wrong, but like I was sure from the comment sections that I was reading that the WHO,
oh God,
was definitely in that. They were definitely telling us we were gonna have to lock down, and like my boy Donald Trump was saying.
Sorry, Mom.
That's what I was getting from those comment sections. But when you read that notice that they put out, it sounds like that's not really what they're saying. So I'm just saying that's confusing for me.
Okay. So what do you have anything more on Mpox?
No, that's it.
Okay. Well, I just wanted to say this because this has been like the more. This is also helpful because I'm trying to like think about this and I'm gonna have to say it and narrate this. So I'm trying to think about like how to say this the most like concisely as I can. So one part of this HIV story, and obviously talking with Trevor, we were talking about HIV. Looking back into the 90s. So there's like deaths per year are just like ramping up and ramping up and ramping up. Every year it's getting worse and worse and worse. 1995, there was like a little over 40,000 people in the US alone that die from AIDS. A drug gets released in 1996. And over the next 2 years, that number goes from 40,000 to like 15,000. So like dramatically
Drug's
drops off by 2/3 because of this drug that came on the market. This drug was manufactured, and every drug has this like crystal structure of the drug molecule. It's got this like solid form. And then it was being made in this specific way, in this specific crystal form. The crystal form of every drug affects the way that drug goes into your body and the way that your body absorbs it.
What do you mean by crystal form? Do you mean like
so like the molecule
before it's ground up and snorted?
So like the
off of
Yeah,
a
right.
really nice male booty,
right? Like the microscopic form of the drug molecule has like a crystal structure. Like if you look at it under a microscope, you can see the crystal solid structure of what the drug molecule looks
like it's worth a lot of money and it could puncture a human.
Exactly. And so what that crystal structure is, like the way that crystal structure is formed has a massive impact on how, when that drug goes into your body, you take it then like absorbs, and then the drug then does its thing. Every drug has tons of different crystal structures that it could form into.
And what is the factor that can change the crystal structure?
Okay, so that's a little bit over my head.
Okay,
but basically, a drug company will give a drug compound to another company that does this work specifically.
Yeah,
and they'll go and they'll find all the different possible crystal structures that drug could take.
Crazy.
And they look at each one of those and their properties, and they find out which one of these is the most suitable structure to put into a drug form that's the easiest way to deliver it to a person who needs it.
So there's like pros and cons to different crystal structures?
Yes, exactly. If
you get a different crystal structure for Viagra,
it'll do something different.
Yeah, that's right. Yeah. It'll actually reduce your boner.
Oh,
right,
really?
Exactly. Which is what you don't want.
Is there other structures that make it do different things?
Oh, yeah.
Well, it can give you a different structure.
Yeah, it will. Yes, actually, I looked into this. So there's a crystal structure when you take it. It will actually make you end up having a boner like a dog. So it's like a big red lipstick.
Right. Wow.
It's apparently extremely painful.
Yeah. Right.
And scary.
So like that crystal structure, they would be like, we don't want this one, so they would get rid of that one.
Well, some people are in. Some people
different strokes for different folks.
That's right. That's
so
right.
it'd just be a different brand.
Brand
that differently.
Right. Yeah. So
sometimes a pup needs sometimes a pup needs a good little. It's not sexual.
Yeah. It's not. No, it's not. Not at all. It's just a hobby. Okay. So
just a hobby mask.
Yeah, just a hobby mask, dog leather mask. So this drug is made, and it's made in this very specific way with this specific crystal structure that makes it so that people can put this in like a pill form, and they can take it. It's easy. They just pop the pill in their mouth, and then it's like now HIV goes from being a death sentence to like a manageable disease for like over 1 million people. Then at some point, randomly, the drug stops working for the people that are taking it. The company that manufactures the drug started looking at this and going, oh, the crystal structure spontaneously, no idea how, just changed structure.
Then they
no idea. Dude, I know this fucking. This is planned obsolescence, brother.
So
Apple was like, "Yo, you guys make drugs? You guys want a real cool tip to make a lot of money?
Make
the crystal structure so that in 2 years you gotta get a new one."
Wow, that's actually really funny, and really sad, because it's so true.
What is it all about?
What is it all about? Okay, so that all about. So this crystal structure changes, and now all of a sudden this drug is not working as it was intended to. They look at it and they go, "Holy shit! The crystal structure has changed. We have no idea how this happened. It like spontaneously just
combusted,
like Genesis. It just spontaneously
God's
occurred."
plan.
Dude, I wish I had a Genesis song.
Now this is the craziest part.
Up there.
This is the crazy part. This structure of the drug, once it spurred into existence, eventually there would be no possible way to ever make that original form of the drug ever again. Because if you entered into a room that had this spontaneous form of this crystal structure and it got into your clothes, it's like a pandemic. That person, if they enter any space where that drug is present, that drug changes. It's like an airborne contamination of the drug.
It sounds magic.
This sounds like
I know it's insane.
This sounds like a fucking the plot of like a really good Disney movie or a Pixar movie that's talking about like, the life of bugs, or not bugs, but like Like the life of like microbes. It's like inside out for microbes.
It's
Yeah.
absolutely nuts. So let's say somebody from the drug company goes, let's say the person that looks at it and goes, oh wow, it's changed structure. Then that person goes to another manufacturing facility on another continent, and they enter into that manufacturing facility to like see what's what, to see if this is happening there. By the virtue of their presence,
They fucked up the whole supply.
and then like a virus, the whole global supply of this drug
But hold on, you
changed into this form.
You don't understand how or why this is like you don't.
They couldn't explain how it's called a disappearing polymorph. So polymorphism is the ability of a drug molecule to have different structures.
Man, and you guys fucking sitting here going like aliens aren't real, and you hear this shit and you go, well, yeah, I thought, well, it's a non-existent polymorph, but that's science. And I'm
Anyway.
like, yeah, right, but like aliens have been here and visiting us. We're like, oh, are you fucking crazy, dude? That's nuts. That makes no sense. It's like, well, this makes no sense.
It's wild
and
that
this
it
is
doesn't
our
make any sense.
reality.
It's wild that it's like if a tree falls in the woods and nobody's there to see it, did it make a sound? Like it's like that. Like you can't, because the only way that you could possibly observe it, if
Or
you knew that this
action
was
at
happening.
spooky action at a distance. It's like it's these things that make me go, we're in a simulation. This is all it's all fake. None of this makes sense. This is all insane.
So the long and short of it is that essentially this drug that worked for like hundreds of thousands, if not millions of people, all of a sudden
Has to
would
be
not
pulled.
would not work. It had to get pulled. Global recall on this drug.
This specifically was that HIV drug that was
Yep.
primo.
Yeah. And then so the company
Wow.
then had to go back and figure out a different way to make another crystal structure that would do all the things that it needed to do. And they had to make a whole bunch of sacrifices in terms of like you used to be able to take it in a pill form, then you had to take it in this liquid form that was like, had this crazy alcohol solution that made it taste like shit. And then, so people had to take it like that. And then they eventually did find their way to making a more like palatable version of it. But, it cost the pharmaceutical company, billions of dollars.
Good.
It costs and then it costs the people that, all of a sudden there's like this huge population of people that were relying on this drug that were now like, am I going to be able to take this drug? Is my HIV going to turn into AIDS? Like,
Yeah.
it was a crazy.
That would be like your
crazy
trifecta,
moment.
just like
Yeah, yeah.
overnight. It's like, oh fuck,
Sorry, dude, the crystals changed. Sorry, dude, you didn't charge those crystals in the full moon last night. Now all your trifecta's fucked.
It's kind
brother.
of hard it would be hard to explain to a population that that's what happened. They would just be like, but why?
Yeah.
Like, why doesn't it
So
work anymore?
We're gonna explain this story on an episode of New Wave that's coming out in I don't know when this
Oh, wow,
when this
sneaky
episode's
plug.
coming out, but it's
Sneaky plug.
coming out in the show. The season is coming out in September, and one of the episodes is going to go into this and highlight a company from here in Nova Scotia that basically works with pharmaceutical companies to make sure that like that never happens.
Crazy. Well,
Wow.
thanks for that wild story that I still just can't wrap my head around. But curious about these crystals. And speaking of crystals, it was a full moon last night, and which means that if you don't subscribe, like, or leave a positive comment on this podcast and send it to 7 people that you love, then you are going to experience bad luck and bad breath for the next 7 years.
We didn't make that rule.
Well,
That just
Nope.
Got it in my inbox, and that's how it is.
That's right. That's just the way the planets spin, brother. So you can do that, but you can also, if you want to also potentially save yourself from horrible, stinky old breath for 7 years, come on over to our Discord, fun little community we've been building up, and it's free, and you can find the link to all the Discord, to all the show notes and all the shows and episodes. So there you go. And
Jeremy's no longer with us. If you want to be a guest on the show, go to sickboypodcast.com and fill out the guest form.
And thanks as always to the folks who helped make this show happen. A huge thank you to Donovan Morgan for the sound design, and to Jeff Lonis, our manager. We love you both very, very much.
that's it for this week.
I'm Brian.
I'm Taylor.
And I'm Jeremy, and this is Sickboy.